I want to welcome everybody to tonight's Wu University event, Myopia Management, the Science and Clinical Application with Dr. Ariel Sorenzi. I'm your host, Dr. Jennifer Stewart. And thank you to Cooper Vision for exhibiting at tonight's event. Just some housekeeping before we start. For each hour of CE, attendees must be online for a minimum of 50 minutes. For a COPE certificate, please fill out the survey link in the chat. Also, the survey link will appear when the webinar ends. CE certificates will be delivered by email and sent to ARBO with OE tracker numbers. We'll also display a QR code at the end of the event if you have the OE tracker app on your phone. CE certificates will be emailed within 4 weeks. Throughout the presentation, feel free to ask questions using the Zoom on-screen floating panels. You can either use chat or Q&A. If you're on a mobile device, you can find the Q&A at the top, and you can find chat under More. It's my great pleasure tonight to introduce Dr. Ariel Sorenzi. She's a specialty lens and myopia management enthusiast. Her passion derived from witnessing the profound impact specialty contact lenses have on improving the current and future lives of patients. She cold started a practice called Charlotte Contact Lens Institute to focus solely on these specialties. Dr. Sorenzi attended optometry school at the University of Houston College of Optometry and completed a cornea and contact lens residency at the University of Missouri St. Louis College of Optometry. She's a fellow of the American Academy of Optometry and the Scleral Lens Education Society, and is a member of the American Academy of Orthokeratology and Myopia Control. She loves spending time with her husband, James, her daughters, Sophie and Adeline, and 2 needy dogs, Remy and Otis. She enjoys water skiing, mountain biking, weightlifting, and moderating Wu events. Dr. Sorenzi, I'm going to turn it over to you, and we'll see you at the end.
Awesome. Thank you for that introduction, Jen. So those are my financial disclosures, all of which have been mitigated. And yeah, I'm excited to be on this side of Wu U. You know, moderating is super fun. We have a lot of talented speakers, but it's kind of fun to be the speaker. So myopia management is one of my favorite things to talk about. And in fact, it's one of my favorite things to do in clinic along with specialty contact lenses. So myopia management really changed kind of like my optometry journey, if you will. And that it was a dream to start a practice where I could focus on those 2 specialties. And I still remember one morning I was in the kitchen with my husband, who was kindly making me breakfast. I was like 5 months pregnant at the time, so it may have just been like a defense mechanism. But I was looking at my schedule for the day, and I saw that I had a lot of myopia management and specialty contact lens patients. And I thought, you know, how happy it made me that I got to see more of that specialty versus, you know, the routine patients. And I told my husband, I said, man, if I could see these types of patients all day, every day, that would be the dream. And so then we really started looking into this dream. And after we had our second baby, we opened the Charlotte Contact Lens Institute. And that's pretty much all that we do all day, every day, is see myopia management and specialty contact lens patients. I just had a doctor join the practice, Dr. Danny Heelan, and it's been awesome. And it truly is a dream to do these 2 specialties. And the reason why I say that is because, you know, you're really changing patients' lives. And that sounds kind of cliche, but think about what other, you know, profession that's out there that you can make such a profound impact on the quality of someone's life. Something as precious as what I think would be my most valuable 5 senses is vision. And I just think it's so cool that we have the opportunity to make such a big impact in patients' lives. And so that's one of the reasons why I just love this specialty so much. So in this presentation, we're going to cover 3 main topics: the importance of myopia management, the risk factors for developing myopia and high myopia, and what some of the options that we have to treat progressive myopes. We're going to take that science that we'll review all of the literature surrounding myopia management and make it clinically applicable. So let's first start talking about the importance of myopia management. Well, we know that myopia is increasing at an alarming rate. And in the US, it's projected that by 2050, 58.6% of the population will be myopic. But note that this study was back in 2016, or this paper was back in 2016 before a little something called COVID happened and a little something called quarantine myopia happened, where I think that this estimate is largely underestimated and we'll see higher rates than even what this predicts. So why does myopia happen? The main theory is that it's from stimuli that happen in the peripheral retina. So what I mean by that is if we look at these image shells of an uncorrected myope and then a corrected myope that's corrected with traditional correction, like single vision contact lenses, single vision glasses, what happens in those that are corrected by these modalities, they have a clear focal point on the retina, but then there is a hyperopic shell that is behind the peripheral retina. And it's thought with the most commonly accepted theory that this hyperopic defocus causes the peripheral retina to grow to meet that image shell. So as that eye elongates, then we become more myopic. Then we add more minus to the prescription, and the cascade continues. So it's thought that the optimal correction, which we'll see both ortho-K and multifocals or our dual focus lenses, have the optimal correction of bringing that hyperopic defocus forward in front of the retina to decrease that stimulus of growth. So the problem with myopia is this axial elongation. That's what we worry about. We worry about the consequences of axial elongation. Axial elongation can put us at risk for things like glaucoma, retinal detachments, myopic macular degeneration. And we know that the higher the level of myopia, the more at risk we are for developing these conditions. So if we look at this chart that was developed by Flitcroft and colleagues, you can see that the level of myopia is there on the left, and then the diseases on the top. Where those two meet is the relative risk of developing that particular disease for that level of myopia compared to an eye that was emmetropic. So if we look the far bottom right, so 41 times the risk of developing myopic macular degeneration if you are over a -6 than if that eye stayed emmetropic. And if we look at it another way, each additional diopter of myopia significantly increases the risk of these diseases. That's really concerning because we're seeing that these children are progressing at very fast rates. It's not uncommon at all for us to see a diopter of progression in a year for some of these children. And look at these numbers, 58% increased risk of myopic macular degeneration with just one diopter of progression, 20% increased risk for glaucoma, 30% risk for retinal detachments. You know, it really makes sense why some of these diseases, especially retinal detachment, are at higher risk of happening with axial elongation. But I kind of wanted to look a little bit more as to why glaucoma would be an increased risk factor and myopic macular degeneration. And it's really pretty interesting with glaucoma. The reason why there is an increased risk for the development of glaucoma is because of two of the main things that happen with axial elongation. And that's anatomical changes that happen at the level of the optic nerve head, where the RNFL that's going towards exiting the eye is getting really stretched over that area of that like choroidal crescent that we see in the right-hand side. And then right opposite of that, nasally, we have this really sharp angle that the RNFL is going to exit the eye. So in both of those cases, the RNFL is very vulnerable to IOP fluctuations in the eye. So that is one of the risk factors related to axial elongation to cause glaucoma, but also the oxidative stress that happens from the choroidal thinning in the eye. And if we think about glaucoma, those are the two mechanisms that we think about is structural and, permeability or the oxygen delivery, nutrient delivery to our nerves. And myopic macular degeneration also makes sense. The choroid gets very thinned, very stressed, and that is what provides nutrients and takes away toxins for our retina tissue. And the thinner the choroid, the more severe the disease state of macular degeneration. So we may ask ourselves, should we be thinking about myopia as more of a disease state versus a refractive error? And that's definitely a big shift in mentality for us because, I mean, myopia is our bread and butter, is what we see every day, all day, every day. And to call it a disease almost seems a little bit of a stretch, right? But the literature tells us otherwise. Like some of these papers are shifting from calling it just a simple refractive error to an eyesight-threatening disease. This is another paper that talks about how there's no evidence of a safe threshold level of myopia for any of the known ocular diseases linked to myopia, including myopic maculopathy. In response to all of this mounting data that we have of the prevalence of these diseases associated with myopia, the World Council of Optometry passed a resolution for myopia management to really be adopted as the standard of care for practitioners. This was back in 2021. And basically, they defined this as a resolution to first discuss mitigation with patients. If you see a child that is at risk for myopia, to discuss some of the things that can help mitigate that risk, like going outdoors more. There's also evidence that sleep hygiene is very important, getting an adequate amount of sleep every night, taking breaks from near work, getting up and moving around when we've been on the tablet, on our phones, on the computer for too long. And then measuring it very closely, making sure that these patients are coming in for their routine visits. And then when we identify that they do have myopia, to treat it with something that's going to slow the progression versus offering a single vision modality that will, not really do anything in terms of their myopia progression. So, I think it's important to really make sure that we're discussing these interventions with patients. And we'll talk a little bit about identifying patients that are at risk for developing myopia, especially those that are at risk for developing aggressive, progressing myopia, and how it's very important to have these discussions early and prescribe these myopia management modalities. So I mentioned prescribe. I think that's a very important thing to say to patients is that we're prescribing myopia management therapy. And if we think about it as a disease state, we're prescribing myopia management to slow this process down. I've really shifted my dialogue from recommendation to something more powerful like prescribing. So let's think about a drug that we see patients prescribed with weekly, if not daily, if not multiple times a day. And a statin is mentioned in this particular paper with Dr. Mark Bullimore. And they talk about the number needed to treat, meaning how many patients do you need to treat with a particular drug to benefit one patient to prevent whatever incident that we are trying to prevent with this particular drug. So for a statin, we are trying to prevent heart attacks and strokes. So I wrote this number down so I remember it. And now I can't find it. I think it's 200. Oh, there it is. So to prevent one patient from having a fatal stroke, 313 patients must be prescribed a statin. And then for a heart attack, 217. So these patients are taking these drugs with all of these side effects with a very unlikely chance that it's really going to be benefiting them in the first place. Well, Dr. Mark Bullamore's paper this is a really cool paper where they talk about the number needed to treat for myopia management. And that number is somewhere around 5. It varies depending on the ultimate level of myopia. But I think that's pretty remarkable. We can just treat 5 patients with some myopia management options to prevent 5 years of visual impairment. I think that's really powerful when we think about all of the other things that patients are loaded down with in terms of their drug list that they bring to us. So, we talk a lot about disease, a lot of the scary stuff that we think of as doctors and taking care of these patients later in life. But what I think about, and I think what's a little bit easier to think about in that moment as that child is in your chair, is that their world is getting blurrier and blurrier every year. And when I think about this through my child's eyes, I would do everything that I could to prevent them from getting like how this, somebody would see in the bottom right. And I think parents would too. We just have to help them understand that this is more than just a nuisance of wearing glasses. So I would encourage you to think about this as well when we see these patients in our chair, in addition to some of these concerns of disease that we just went over. So what are some of the risk factors for developing myopia? So if we see some of these patients in our chair, how do we know that they are likely to develop myopia and at that become rapid progressors to ultimately develop high myopia? Well, first is refractive error. Refractive error at a specific age before they become myopic is the best predictor of future myopia. And it's more of a powerful predictor than genetics, near work, and the other risk factors that we'll go over shortly. Those ages are listed here from the CLEAR study. It's ages 6 through 11. And on our right there, we have the refractive threshold, so meaning that they need to be at least this hyperopic. So if you have a 7-year-old that's in your chair and you determine that they have a plano prescription, then it is very likely that they're going to become myopic in the future. How we deal with this in practice and in a true clinical setting is to have discussions early. So I may say something like, as your child develops, we expect their prescription to develop in a very specific range. And your child is outside of those normal ranges, which concerns me. It concerns me because it's very likely that he or she is going to develop myopia. And then I'll explain to them a little bit about what myopia is and why it's a concern to develop myopia really early in life, that myopia progresses quick. Their eye is getting too long, too fast. And we have these visual implications, and then we have these risks for diseases later in life. Now, you may think, well, that takes a really long time to have that discussion, but how easy is it to have an exam on a plano 7-year-old? You're not having to talk about, any disease states or dry eye or whatever. So we have a little bit of built-in time, and that will pay off in the end when it is time to do some sort of myopia management option, because parents are going to be on board. They've been educated on it, and typically they're ready to start once the child becomes myopic. The younger the age of myopia, the faster that they progress. And if it occurs before the age of 10, then 26% become highly myopic. And if it's more than 10, if it's later than 10 years old, then only 1% become myopic. And if it starts really early in life, then we have to think about when is it going to stabilize? According to the COMET study, myopia stabilizes for most people around the age of 21. You can see the percentages below the ages. 75% stabilized by the age of 18. But we know that we see adults all day that are still progressing. And a lot of that has to do with probably the fact that we're all on, computers and devices and doing a lot of near work throughout the day. But I mean, look at this chart from Dr. Mark Bullimore. Even up to the age of 40, 25% of this patient population that he was seeing progressed by at least 3/4 of a diopter. Some other risk factors that we have are genetics. So this would be compared, these numbers here are compared to a child that has 2 emmetropic parents. So if a child has 1 myopic parent, then he's 2 times more likely to become myopic. And if they're both myopic, then 5 times the risk. We know genetics can't be totally at play though, because myopia is increasing all across the world. Even in rural areas, we're seeing that myopia is increasing significantly. And again, these are projections that are based off of retrospective information from the Brian Holden Vision Institute. Why is that? Probably from all of the near work that's happening more and more across the world. And when we talk to parents about myopia management and they're kind of confused why their child is developing myopia and maybe neither one of them have myopia, once you start talking about the visual environment that their children are in versus the way that they grew up, it really hits home for them. Near work is a significant risk factor. More than 3 hours of near work is a risk factor. Close working distance. So it is true. If a child holds something really close, it's has more of a dioptric demand on the retina and creates more of a hyperopic defocus behind the retina. There's actually a little formula that this review had where it's 2% increased odds of myopia for every additional diopter hour of time spent on near work per week. Also, so both continuous and cumulative work, near work are risk factors, but not taking breaks or just having continuous near work is more of a risk factor than taking breaks, just like the overall amount of near work that's done. And we all know that when we walk into exam rooms, we always see, or it's not always, but we often see if a child has a phone or something, they're holding it like 3 inches from their face, right? There was an iOS update probably 6 months ago where if you go into the settings, if your phone has been recently updated, you can go into screen time and toggle on screen distance. It's really cool technology where they use Face ID to make sure that the phone is held at a certain distance away from the face. And it'll actually make it to where you can't interface with the screen until the phone is moved to the appropriate distance. And what I think is really cool is it actually mentions the risk of myopia in children in this in the little explanation underneath the screen distance toggle button. I love this picture. So this is a school in Southeast Asia where they know that near work is a concern for the development of myopia, and they have these little bars set up where children have to keep a certain distance away from their work. I don't know if y'all can see me, but see my mouse, but on the picture in the left, I just love this little girl. It's like, screw your rules. I'm going to do what I want. Now, outdoor time has found to be protective and something that we should definitely encourage. This paper is pretty cool. It looked at actually separating the risk of near work and minimal outdoor time. So I'll walk you through we'll look at the left side here. So if a child does a lot of near work, if they are also outdoors a lot, then their odds ratio is much lower than somebody that does a low amount of outdoor time, but still a high amount of near work. There is this little outlier here. You know, science isn't perfect, but for the most part, we can see this this correlation between more outdoor time being protective. There are several theories. Most of them center around the light spectrum that's outdoors. Also, the dioptric demand. There's less dioptric demand on the retina compared to when you're indoors. I mean, right now I have two screens in front of me. I have my phone. You know, I have this desk. The dioptric demand is very high versus when you're outdoors, things tend to be a lot further away from you. There's also theories on the way that the vitamin D causes a dopamine cascade effect in the retina that's very similar to how we see atropine work on the eye. Another risk factor is accommodative lag. This is both a risk factor for onset of myopia and also fast progressors tend to be, there's a high correlation between high accommodative lag and those that are fast progressors. Kind of going along with the BV theme, esophoria is also found to be associated with more progressive myopia as well. And then lastly, these statistics are pretty alarming. Intermittent exotropia is associated with a higher prevalence of myopia as well. 50% of children with intermittent exotropia are myopic by the age of 10 and 90% by the age of 20. So this is a nice little summary to kind of put a little bow on the last risk factor topic that we went over. It's from Myopia Profile. I love this website. It's constantly being updated with the most recent literature, clinical articles. So I'd encourage you guys to check out that website. There's a little QR code at the top, but it just summarizes all of the risk factors that we went through in this so far. So tips is we really want to stress the importance of outdoor time. Actually, on Myopia Profile, I saw a really interesting article where they looked at the dioptric demand of the retina in a very conventional classroom setting, and then they did a classroom setting with less spatial frequency that had a lot of outdoor decor, like trees and stuff like that, and they found that it had less of a less stimulus onto the retina, and I just thought that was interesting. But encouraging outdoor time, discussing breaks from near work, making sure that we're doing a binocular vision assessment, just a quick cover test and looking for accommodative lag, and then starting that conversation early and making sure they're coming in for their follow-ups appropriately. So let's get into the good stuff, what treatment options we have and how to prescribe those options. We'll go from things that we don't necessarily want to recommend to things that work well to options that are on the horizon. Less effective options. Let's first start with just not wearing any correction at all. Well, if we look at the left graph here, what we can see is that we have progression in diopters as we go down on the y-axis, and then the follow-up time in years. Those that were not corrected actually progressed more than those that were corrected with spectacles. Now, it is a 0.09% difference. Is that clinically applicable or clinically, significant? No, but this is a very good thing to be able to tell those patients that said, ever since you prescribed me glasses, my prescription has gotten worse, and I think it's because of the glasses. You can tell them, absolutely not. The data does not back that up. In fact, if you were not to be wearing correction, your vision would have got worse faster. Undercorrection. This study looked at, well, maybe if we can just undercorrect by 3, this one was a half diopter, maybe that would help with myopia progression. What they found was the opposite again. Those that were fully corrected progressed less than those that were undercorrected. Again, not much of a clinically significant difference, 0.17 difference in 18 months. But the deal is that it doesn't work, so why do it? So bifocals and progressives. First, we'll start with PALs, so progressives. For the most part, they slow progression by about 20% on average, aside from this outlier that we see from the COMET study in 2003. It works pretty well for those folks, and that was a very specific group of patients, those that had that were ESO4s and had an accommodative lag. So if you have those patients, remember, those are the ones that are going to progress more rapidly. If they can't do contact lenses or atropine for whatever reason, then a PAL would be a good option. And I believe for that group, it was a +2 ad that they used in the COMET study. The bifocal, the group in the red, about 20% control again. And then if you want to subject a child to the trauma of wearing an executive bifocal, then prescribe them a +150 with a 3 diopter base and prism, and it has, pretty good control for the options that we have related to spectacles. But I wouldn't do that to my child. I wouldn't want to put them through that, but it's an option nevertheless. Multifocals. So for our contact lens options, we have monthly SiHys and monthly hydrogels that can go up pretty high in terms of correction and can correct SIL. So these are great options if you have patients that have a lot of SIL or are very highly myopic. It is very important to stress that these patients need to be in a center distance multifocal. Center near has not been consistently shown or really shown much at all to have much of a myopia control effect. In our daily options, we have, of course, our FDA approved option with MiSight, which is not a multifocal, but I put it in this because it fits. But it goes up to a -7 diopter for the prescription availability. And then we have natural view, which goes up to a -1225. So, of course, we can still correct patients that have some amount of astigmatism correction, given that they still have relatively good acuity with that prescription. How these work is that they're pulling that hyperopic defocus shell that is now behind the retina for our corrected myopes, to pulling it in front of the retina to have myopic defocus. And it's done by different ways depending on what kind of lens that you're in, whether it's a gradual change in plus or more of our dual focus, like what's in the MiSight lens. This study was from the Blink group, and what they aimed to determine was how would a high ad, a +250 center distance lens, compare to a medium ad, all compared to a control of a single vision contact lens. So they randomized about nearly 300 kids into either a high ad group, medium ad, or a single vision contact lens. And what they found is that the group that's in the navy there, the high ad power, you can see that their change in myopia was less over time compared to that lighter blue, the medium ad, and then the single vision over a 3-year period. There was about 43% of less progression compared to the single vision in the high ad group, and 36% less for the medium ad group. So I think those numbers are important to remember, because we'll look to see that, with our FDA approved option, it's much more effective. And that's because it was specifically designed to be a myopia control lens. Now, if we need to prescribe this lens for prescription availability, then know that you will likely have to prescribe a little bit more minus than what their actual prescription is to allow that child to see well. There was a really interesting podcast episode on Dr. Dave Kading's Myopia podcast where they had Dr. Jeffrey Walleen talk about this study. And they did have to, kind of like overcorrect the kids in the study to allow them to be able to see well. Now for the MiSight lens, this is the FDA approved ranges because these were the children that were enrolled in the study. They were ages 8 through 12 with a refraction of -3/4 to -4, less than 3/4 of a diopter of astigmatism. We already talked about the way that this works is by having the correction zone in the middle to allow the child to be able to see, surrounded by these +2 myopic defocus to bring that hyperopic defocus image shell forward in front of the retina. They had 109 children and they were either randomized into MiSight or ProClear. And in the first 3 years found about a 59% reduction in myopia. That very tightly correlated with axial elongation reduction, which it should. And there were no cases of serious ocular events reported at that time. So I want to think about this from a different way, from thinking about diopter change to changes in axial length, because this offers a very cool perspective. The group in the orange is the ProClear group. The group in the purple is MiSight. As we go up the y-axis, that's change in axial length in respect to time on our x-axis. So what we can first see is that the axial elongation was slowed by, anywhere from 2 to 3 times, on average 2 times less than the ProClear group. Well, interestingly, for this particular age, 0.1 millimeter axial elongation per year is about what an emmetropic eye would be progressing. So the MiSight lens slowed the progression of these myopic children, their axial elongation, to that of what an emmetropic eye would grow. As the child grows, as their head gets bigger, as their brain gets bigger, their eye does have to get a little bit bigger over time, and that's normal. So then after that 3-year period, they presented their findings to the FDA, and the FDA said, well, clearly this works. It would be unethical for you to continue with a control group, so everybody needs to be moved to MiSight lenses. So that's why we see this dotted purple line. Everybody's moved to MiSight, and you can see that there's a pretty dramatic shift in that axial length progression, that axial elongation. Now we see lower numbers because these children are older and that normal emmetropic growth rate is going to be less. Then importantly, at the end of the 6 years, they took everybody out of MiSight and found no rebound. In general, as was found in the MiSight study, children can safely wear contact lenses, and that's probably the biggest concern with parents is safety of contact lens wear in their child. There's 2 really big studies, the Clay study and the Recess study, and you can see that the younger age groups had less incidence of complications related to contact lens wear per year compared to their older counterparts. Specifically, the Recess study looked at 1,000 children over the course of 2,700 years of wear. And these kids were less than the age of 13 when they started the study. And they found that the annual incidence of any sort of inflammatory complications were less than 1%. They did conclude by saying that a daily disposable should be preferred if available, so you can eliminate the need for solutions and storage cases, which are, risk factors for infection and inflammation. So now let's go into orthokeratology. Orthokeratology is FDA approved for myopia correction, so not control, in these ranges here, up to a -6 sphere and then -1.75 of astigmatism. How this works is basically is from hydraulic changes that happen with the fluid beneath the lens, the tear film that's beneath the lens, and then the fluid in the epithelium. So along that base curve, we have some downwards pressure that's placed on the central portion of the cornea. And what it does is it doesn't squish the epithelial cells, but it makes the fluid go through the gap channels and escape to the path of least resistance, which is right underneath our reverse curve. As you can see, the reverse curve has lots of clearance beneath it. The base curve has clearance beneath it too. It's just minimal, and it definitely it shouldn't be touching the cornea. So now we have all of this, the fluid in the reverse curve, and then in the alignment curve, we get further, we have alignment there. So the fluid is escaping either out towards the edge or the other way towards the reverse curve. What we get is a topography that looks like this. So that mid-peripheral steepening, that red ring that we see here, creates peripheral plus in the retina. So much like the multifocal creates peripheral plus out in the retina, so does orthokeratology, but through the shape of the cornea. And there are some studies that show that some of the smaller optic zone diameters that you can prescribe with some of the brands that are available may be more effective in slowing axial elongation. And that makes sense when we think about the mechanism. The more that we can put that peripheral plus within that pupil zone, the more of an effect that we will have. We expect that orthokeratology will have about a 50% slow axial elongation by about 50%. It does vary based off of the design, how the lens is designed, but around on average, it's about 50%. A lot of folks worry about the safety of orthokeratology, and that's because it was largely unregulated in a lot of areas of the world, and there were all of these really scary case reports that came out. But when we look at orthokeratology that is prescribed the way that we would prescribe it, it's a very safe option. This particular study was a 18-year follow-up study and found that of the patients that were in Ortho-K, they saw some complications in adults, but in the kids, there were 0 cases of microbial keratitis. There was just, some corneal staining that was observed as the most frequent adverse event. This is another paper that was a systematic review and said similarly that orthokeratology is a safe option for myopia correction and slowing of myopia. And we just need to make sure that we're fitting these patients correctly. We're making sure that they're taking care of their lenses properly. They're coming in for their follow-ups. And if there are complications, that we are addressing them in a timely manner. So when we prescribe orthokeratology, we want to have a cycloplegic baseline refraction. We want to do, and this is for orthokeratology and multifocals. We'd want to do a quick BV evaluation, biometry if you have it. And then for orthokeratology, for sure, we need to have topography to see, to address any sort of fit challenges that we may be having. So I think topography is a must for prescribing Ortho-K. It's also good to have just Ks in general for multifocals because we need to know how the cornea shape may change over time. And in general, it's also good to have topography for these young myopic patients because, kind of a side note, pediatric keratoconus, for example, is more prevalent than what was previously thought. So then we want them to either return to clinic for dispense and insertion and removal training. I think it's very important to counsel these patients on expectations. So with multifocals, the child may experience having halos. I see this pretty commonly in children that were in single vision contact lenses before switching to a myopia management option. These are typically the kids that complain the most, but it doesn't happen very often. I think it's still important to set those expectations. That way, if it does happen, it's not a concern. It's, okay, we knew that this may happen. There may be more dryness. They may have some issues with allergies. And then a big one is there's going to probably be a little bit of drama in the morning before school. talking about that that's normal. Give yourself a little bit more time to practice in the mornings. Maybe they start by having their first day on the weekend. I think that that's the biggest one to talk with parents about, because ultimately they have to go home with these kids that are going to be emotional about putting their contacts in the morning or at night in the case of Ortho-K. With Ortho-K, I think it's important not to promise a perfect Plano prescription. We may have like a little bit of residual prescription, probably hyperopic. But if it's a little bit myopic, then the important thing is that Ortho-K is working. Most of the time, I'd say the large majority of the time, you're able to get them to a nice solid 20/20, but that may not always be the case. We need to really stress the fact that there's going to be some comfort issues in the beginning. Put a drop of artificial tears in your eyes before putting the lens on. Put a drop of artificial tear into the lens, and that can help. Then vision expectations, they too may have some of these halos and changes at night. And then really kind of counsel them on how their vision will change in the beginning as they start to wear these lenses and build up the wear time or the prescription changes that will happen. So atropine. Atropine is nice because there is no limit in terms of refractive error. What's not so nice about it is that we have no idea how it works. There are lots of theories that perhaps it works at the level of the retina. Maybe it works at the level of the choroid by thickening of the choroid. Maybe it works at the sclera by blocking the proliferation of scleral fibroblasts, and which is would result in axial elongation. We don't really know for sure. But what was really interesting is for a period of time, 0.01% was the go-to percentage to prescribe. And that was because in the ATOM study, they talked about the refractive efficiency of 59% slowing of myopia compared to placebo. But they failed to mention the fact that when they measured biometry, that there was no correlation between biometry and the refractive efficiency at all. So the data just didn't really make sense. So there's more studies that have come out that show that 0.01% really isn't that effective. Or the large majority of studies show that anyways. 0.05%, according to the LAMP study and other studies that have recently come out, show that it is the most effective concentration of slowing myopia by about 66%. And that has a very tight correlation with its axial efficiency as well. The study concluded by saying that it was the optimal concentration and that rebound effects were clinically small across all of the studied low-dose atropine concentration, and stopping at older ages was associated with a smaller rebound. The issue is that there's no standard way to dilute atropine, or how to prepare atropine. So some of these concentrations that were used were prepared by diluting atropine drops or atropine powder. Different preservatives were used. Atropine in general is just a very unstable compound, and it's influenced by pH and whatever else is in that bottle, like the preservatives, whatever it was used to dilute the atropine. And in an analysis by Dr. Richdale and colleagues, they found that a large percentage of the samples that were tested were actually under the 90% target concentration. So maybe 0.05% is so effective because as it kind of starts to break down over time, at least you're still getting a good chunk of concentration of the drug versus starting off at 0.01%. But that's why some of these studies report variable side effects. Some had lots of stinging and photophobia, effects on accommodation, while others reported minimal side effects. The most common side effect is going to be allergic conjunctivitis. So when we prescribe atropine, pretty similar to our contact lens options, we want to get a cycloplegic baseline refraction, BV eval, biometry if we have it. We also want to take a look at the pupil size and response and consider visual fatigue lenses and photochromic lenses to help address some potential near vision concerns or light sensitivity. And then we'll prescribe that 0.05% one drop every night in both eyes. And just counsel on light expectations. I typically find that patients may complain of these for a couple of weeks and then they're usually fine. So I just ask them to power through any of these side effects that they may have, like light sensitivity, burning when it goes in, some near vision changes. And then I just counsel parents, like their pupil size is probably going to look a little different, a little bit larger. This is again from Myopia Profile that talks about the frequency of follow-up schedule that's recommended by the International Myopia Institute. So if you want to take a quick picture of that. And then gauging success. I'm not going to go into this in too much depth, but again, just take a picture of it. And this tells us about what we should expect for axial length expectations with myopia control and dioptric control. So overall, we want to shoot for about half, about 50% control. But again, some of these patients that have accommodative lag or are, esophoric, you may have less control than what you think that you're doing. But in reality, a lot of these patients would have progressed much more quickly should they have not been in whatever modality that you offered them. Unfortunately, a lot of the combination therapy data is using 0.01% atropine. So the data is kind of mixed on if it works or if it does not. So hopefully they'll start to have more information with higher concentrations of atropine. But in theory, it should work, right? Like they're two totally different mechanisms, the contact lens mechanisms and atropine. So in theory, they should work. And some of the papers tell us that it does, while some others tell us that it does not. Similarly, with the BAM study, they had the MiSight lens with 0.01% atropine and found that the combination was not statistically significant in slowing myopia. But again, they used the 0.01%. And then some of the things that we have on hopefully coming soon is some of our spectacle options, the MyoSmart or the DIMS lens, HALT, DOT. They show pretty promising results in their overall level of slowing of myopia. It's just a matter of when we're going to have them, but most of them operate off of using peripheral defocus. And then I think it's the DOT lens that uses the reducing peripheral contrast. Red light therapy has been pretty hot on the press, but there's lots of articles talking about the concerns of the safety of red light therapy. This was a particular case where this little 12-year-old girl had some retinal damage and decreased in her best corrected visual acuity after using red light therapy. And even after 3 months, she was still only able to be corrected to about 20/25. So all in all, we know the importance of myopia management. We know what to look for in terms of if patients have some of these risk factors, discussing ways to mitigate those risk factors. And once they do develop myopia, what some of the best treatment options that we have available to us are.